Now, moving on to our second section, that is the proximal humerus fracture classification in case of adults. As I told you, mainly in case of children, its Salter-Harris classification is mainly utilized. But in case of adult, Neer was the first one to give this classification, and it divided proximal humerus into 4 parts. On that basis, if a single fracture line, 2-part, 3-part, and 4-part fractures were constituted, and then there was also a term for fracture dislocation as well. In this section, we will briefly discuss how this classification comes into effect and what's the treatment options and what is the fracture dislocation along with its complication. Now, if you see the proximal humerus is actually divided into 4 parts. That is, the greater tuberosity is 1 part. The shaft is the 2nd part, lesser tuberosity is the 3rd part, and articular surface, which constitutes the anatomical neck, which actually forms the 4th part. So if there is a single fracture line, which this would divide humerus into 2 parts. There would be 1 part of the surgical neck, and along with the other would be the shaft as well. So if surgical neck is involved, this means most likely it's going to be extra articular. Usually the fragments are manipulated to the alignment, close reduction is done. Again, then depending upon how much displacement is there. If its displacement is more than 1 centimeter and angulation is more than 45 degrees, then probably we may have to go for fixation. But if we achieve the angulation less than 45 degree and less than 1 centimeter displacement, then probably after close manipulation, the arm can be immobilized, elbow and hand exercises can be constituted straight away. And initially the shoulder is immobilized for a few weeks. Later on, passive range of motion is started, and eventually moving on to active range of motion as well. Fixation after course reduction does not actually help. But again, if this criteria is not met, then we may have to go for open reduction and internal fixation, even in the case of surgical neck fractures. But usually, most of the time, they are less displaced and they can be easily managed in conservatively form of a sling. Now coming to the greater tuberosity fractures. It may be associated with anterior dislocation. That is something we need to remember. Could be relocation reduces to good position. Now the criteria for the acceptable criteria for the case of greater tuberosity is actually less than 5 mm of displacement. If greater tuberosity is more than 5 mm of displacement is there and more than 45 degree of angulation is there, then probably we'll have to fix this fracture. But if after manipulation, if less than 5 mm displaced and less than 45 degree angulated, then probably we can manage it conservatively in form of, very simply, in form of sling. But if it is more than this dislocation is there, then we may have to go reattachment via small incision, percutaneous close reduction, percutaneous pinning, and or open reduction internal fixation may be required as well in form of with intraosseous sutures or cancellous screws. Now coming to the anatomical neck fractures, they usually very rare, although that means anatomical neck is a part where it's very close to the articular surface. Although this will almost always associated with fracture dislocation. So in that case, if it is a fracture dislocation along with associated anatomical neck, this must be fixed. Although it's a 2-part fracture, but that means it's involving the articular surface and eventually result into avascular necrosis of the humeral head. So that usually in older patients, we can straight away go for hemiarthroplasty because they have a sedentary lifestyle and they're not maybe using. But if it's a young patient, it comes with the anatomical neck fractures, then probably we need open reduction internal fixation with to prevent high risk of avascular necrosis of the humeral head. Now coming to the 3-part fractures. 3-part fractures would mean that there are 2 fracture lines, at least splitting the proximal humerus into 3 parts. If you see this is a simple surgical neck fracture, and it has divided the humerus into 2 parts. Similarly, if it's only a greater tuberosity fracture, this is also divided humerus into 2 parts kind of a fracture. Now, as I told you, there are 4 parts, and fracture configuration could be such that it splits the fragments into 2, 3, or 4 parts. This is a fracture involving the anatomical neck, although it's a 2-part fracture, but as it is articular in surfaces involved, so sometimes requires fixation. Similarly, it could be a fracture line which is just splitting the lesser tuberosity. So still the humerus is a 2-part because it's not involving the articular surface. But if you see these two diagrams, the fracture line, this is one fracture line over here and other is exiting from there. Now this makes it 1, 2 and 3-part fracture. So in the case, if it's a 3-part fracture, this means either it was involving the surgical neck and the greater tuberosity, or surgical neck and the lesser tuberosity, or surgical neck and the anatomical neck. In that case, it makes it a 3-part fracture. It's usually difficult to reduce because now there is increased combination. In active individuals, we have to go for open reduction internal fixation. Newer implants have come up, which includes locking, plating, and nailing as well. But usually if it is actually a proximal humerus interlocking plate, which is called a Philos plate, which has come up, and it's very effective, especially in the 3-part and 4-part fractures. Now coming to the 4-part fractures. 4-part fracture means, as I told you, proximal humerus has 4 parts. Greater tuberosity is 1 part, lesser tuberosity is another, shaft is the 3rd one, and article surface is the 4th one. The fracture line is such that it splits this proximal humerus into 4 parts, either involving all of the segments most of the time. This is usually high energy trauma and comminuted fracture, and associated with high risk of complications. X-rays usually is difficult to diagnose with a lot of combination, and that is where we need a 3D reconstruction CT scans, because we need to know that how much degree of combination is present over there. There will be multiple displaced fragments, and usually young patients attempt must be made a reconstruction. Why? Because this would split the vascular supply and would result in avascular necrosis of the humeral head. So in the young patients, you have to go for a reconstruction, but in older patients, you can easily straight away go for, if it's a 4-part fracture, for hemiarthroplasty. Now, what is the close treatment usually in case if it's a minimally displaced and non-displaced fracture? Is older patient is conservative treatment in form of a sling. But if it's a young patient, sometimes we have to go for surgical treatment as well. In older patients, most of the time it's a 4-part fracture. We can directly go for hemiarthroplasty or prosthetic replacement of the proximal humerus. Anatomical reduction fixation is indicated in case if it's a 4-part fracture and a comminuted one, but the patient is young, fit adult, then you probably need a Philos plate, which can be seen over here. And healing of the tuberosity has to be waited. Now coming to another term, which is termed as fracture dislocation. Fracture dislocation is usually a term which is associated with the fracture of the proximal humerus along with either anterior or posterior dislocation of the head. Now this is usually associated with high energy trauma. The greater tuberosity may be fractured with anterior dislocation, and usually it's reduced by closed mean, but if it's fulfilling the acceptable criteria, it's okay. Otherwise, you have to go for open reduction internal fixation. Then it's a 3-part fracture dislocation. Usually surgical neck is broken and they require open reduction internal fixation. Otherwise, high chances of avascular necrosis of head. In case of a 4-part fracture dislocation, usually has a very poor prognosis. And if it's a young adult, we will have to go for reconstruction. But if it's a older adults, we can straight away go for hemiarthroplasty or prosthetic replacements. Now coming to the complications which may be associated with proximal humerus fractures. The most common complication is the vascular injuries and the nerve injuries. As we know, the brachial plexus is going through the axilla, and then the axillary artery is coming from this to form the brachial artery, and there could be anterior and posterior circumference humeral artery can be damaged, leading to AVN or avascular necrosis of the humeral head. Avascular necrosis is also very common because if it happens in the young adults, we have to go for some kind of a prosthetic joint replacements, and that in a young adults is not very helpful as well because that gradually wears out quickly. The most common, if the management is done conservatively, the most commonly problem or complication with the conservative management is actually the stiffness of the shoulder. The patient is, if not properly educated, and probably the passive range of motion, then active range of motion and active strengthening exercises are not started later on, then eventually if the shoulder is immobilized for too long, probably results in the stiffness, and which may eventually need a lot of treatment at times as well. The most common could be in form of then you're applying the reconstruction, especially in case of 4-part comminuted fracture. And we are applying the reconstruction, usually there's so much combination that this results in a malunited or a non-united fracture, and eventually may have a malunion and non-union of the proximal humerus, which can be easily seen on the x-rays. In this section, we have briefly gone through the nearest classification of the proximal humerus fractures. Proximal humerus fractures, basically the concept was, which was given by the nearest, that there are 4 parts of the fracture. Shaft is the one part, greater tuberosity is the second, lesser tuberosity is third, and articular surface is such. And the fracture line is such that it splits the proximal humerus into 2, which is called as 2-part. Then if the fracture line is such that it splits the humerus into 3-part, then it's called a 3-part fracture, and when it splits the humerus into 4 parts, it's called a 4-part fracture. As 3-part and 4-part, most of the time we have to go for reconstruction in young adults, or if the patient is old, we can go directly for the hemiarthroplasty. But in case of the 2-part, most of the time, if it's undisplaced and less than 45 degree of angulation or less than 1 centimeter of displacement is there, then probably we can manage this kind of a 2-part fracture in a sling in form of for initially immobilization and sling for 2 weeks, and over 2 to 4 weeks, and go for passive range of motion, and after 4 to 6 weeks we can start the active range of motion for the shoulder. While the patient is in sling, we can keep on active mobilization of the elbow and the wrist joint. Thank you very much. Keep watching sqadia.com.